we have two people at the mic, and I'd like to give them a chance to give their input, and then we will come back to this, because we are now at the heart of what this session was to address. So we'll be right back.
Yeah, this is Greg Simon, and my question is actually directly relevant to what you're talking about now, and it's this the reasonably foreseeable risk construct has been around for a while. I think what is proposed to change here is, if it's an outcome, then it's a risk. If it's defined as an outcome, then it automatically moves into the category of reasonably foreseeable risk. And I want to go back to something Leonard said, where he said it's procedural, not substantive, whether you talk about it in the purpose section or the risk section. I don't think so. I think it's material, whether you talk about it in one place or the other, both in terms of how IRBs view it, how potential participants view it. So the case example I'll give you, very specific to this, I do research in suicide prevention, and when we're testing public health or outreach programs to prevent suicide attempt, clearly suicide attempt is the outcome. And in the statement of purpose, we would tell potential participants, the purpose of this study is to see whether these programs reduce your risk of attempting or dying by suicide. We do not, however, say in the risk section, if you are assigned to this treatment or the other treatment, these things may increase your risk of suicide, because we are in equipoise about these different options. So I think whether we describe it in that case as a purpose or a risk really is material.
I think that one of the misunderstandings is that to say something is a risk, that you know it's a risk. That you could say 5% of the people who do this will commit suicide, right? But that's not the point. That the risk is that depending on what it is you're doing, some of the population may be benefit and some of the population may be harmed. It's an extension of the aspirin thing, which is, some of you are going to bleed more than you might otherwise have, but we don't know who you are and we don't know what it is, and some of you may have fewer heart attacks, but that's the outcome. So again, I think that it's sort of up in the air. I think you can go either way, but I'm saying that I think that since I don't really care about the forms, which is a compliance issue, what I care about is the information that gets to people. That's why, to me, it's more of a procedural issue.
Well, thanks for a great discussion. Jeremy told me that Leonard would get me worked up, and he was right, partly because some of the things Leonard said I'm radically in agreement with, and some things I'm radically concerned about.
And you only had a single dose of Leonard.
This idealistic depiction of the doctor-patient relationship, having run an intensive care unit for a number of years, I love it, and I wish it was true. But it doesn't really depict the shades of grayness that all of us live in who really practice medicine today. We live in a world of protocols where when you deviate from the protocol, when you're not in a clinical trial, there are consequences. You should go to the BU performance review of your cardiologist about their RVUs. And if you think the best interest of the patient is really the main purpose of the RVU-driven world of clinical practice, there's a lot to learn there. However, I don't want to throw that away. It is the greatest thing about the profession, and patients desperately need to have an element of that in there. But if we just present it as a dichotomy, I don't think we're doing a good service to the realities that we have to face as we try to navigate the world. And one of the most important realities to me is when I look at people that refer patients to our practice, those who are not interested in learning, who think they actually know the answers, are the most dangerous physicians, because typically they don't. And if you live in a modern world of learning and information, you know that the best thing you can do for many patients in many circumstances is to encourage them to participate in a clinical trial, because the protocolization of the rest of care from a lot of data is at least as good, if not better, than the choices that are made in clinical practice. Now, like everything that's been said today, it's not always the case. Every situation is individual. So that's my little opinion part. My two questions really have to do with one thing that we haven't heard a mention of, cluster, the C word. I don't see how under what's been said in this panel that cluster randomized trials that involved an intervention could ever be done. because there's no way in most of those trials to get the consent done. Now, I know we have an expert who's published a lot on this, but I think it would be good for people to hear a bit of discussion about how this fits in with the very large health system-oriented cluster randomized trials that are currently ongoing. And the second thing is, I do believe in a nuanced world. What I've heard people say is, okay, not every foreseeable risk. Somehow we magically know where to draw that line. But anyone that's lived in a world of multi-center trials sees radically different behaviors by different IRBs that don't make any sense. And there has to be a practical solution to this other than just saying, we've done it this way, so it must work. And I wonder if people have some suggestion for how to sort of normalize this so that we don't end up with so much sort of impossible to deal with variation about things that are being depicted as common sense.
Yeah, I don't think this has anything to do with cluster randomized trials. I think that that requires an entirely different category of thought. That doesn't have to do with, so what we were talking about is doing research in the context of the doctor-patient relationship. In the cluster randomized trial circumstance, there is no choice for the doctor either. That people are just assigned to this group. So if one hospital only uses X drug and one hospital only uses Y drug, that's what's being used. Yes? No. Okay. Tell me.
So I think cluster randomized trials are a part of this sort of research, and very much a part of it. And I think a guidance that's being offered to address this side of research needs to make sure that it is sensitive. Just because we've been inadequately addressing those from your perspective doesn't mean that the guidance is right on target there. But I'm going to defer to Charles, who led a group that worked on this issue on cluster randomized trials to talk about that.
Well, thanks. Yeah, we worked on this problem for 5 years, and at the end of that came to the conclusion that cluster randomized trials are really complicated. I mean, I can say a couple of things. I mean, I think there are some really important differences with cluster randomized trials. One is that the intervention, often it can be a public health intervention or some cluster level intervention, and I think in those cases it's very difficult to see how individual level consent can possibly be obtained. In other cases, though, cluster trials are really directed at health professionals. And I think that requires some refocusing of our thinking in seeing health professionals actually first and foremost as the research subjects in those trials, and in fact being an open question, in my mind at least, as to whether their patients are research subjects or not. Finally, I would say some cluster randomized trials do involve sort of individual level interventions. And I think our conclusion, for the most part, was that in those cases, informed consent from those individuals ought to be sought. It's a very complex issue. We've issued, a statement called the Ottawa Statement on the ethics and design of cluster randomized trials, and if you're interested, I would direct your attention to that.
There's just one more thing to say about cluster randomized trials, and that is, well, there are many more things, but one important thing is that some of them really are what would otherwise be called quality improvement. And there we have a little disagreement about the nature of the quality improvement and whether it's equipoise. But if the intervention is targeted at the providers, the physicians, the nurses, or whatever. And that's what why the cluster, you're comparing what they usually do with something that could otherwise be instituted in a hospital or a clinic by the head of the unit or the head of the clinic, and it would be quality improvement without a comparator. So what you learn from the cluster randomized trial is no doubt superior to what you would learn if you didn't randomize by cluster, because you'd be introducing something new without that kind of comparison. So the question then becomes, should cluster randomized trials be considered more like research, with all the requirements of research going before the IRB, et cetera, or should they be considered similar to quality improvement, in which nobody goes before an IRB and nobody gets consent, you just do it?
Yeah, I mean, there definitely is room for a conversation on that point. I mean, from the standpoint of our group, we came to the conclusion that overwhelmingly cluster randomized trials are designed as research and ought to be regulated as research. So that's the conclusion that we came to. I think it's important to recognize, though, that many of the interventions in cluster randomized trials, including ones that are looking to improve the quality of practice, in fact, are not the kinds of interventions that we're talking about today. They're not drug interventions. A lot of them are just behavioral interventions, right? We know there's a gap between what the knowledge says that physicians should do and what physicians actually do in practice. And a lot of the attempt in knowledge translation cluster randomized trials is to use behavioral interventions to bridge that gap. Under those circumstances, we think you need to be thinking about the health providers there as being the research subjects, but it's a big topic.
Great.
On cluster randomized trials, if I go to my physician and my physician is treating me a way that he or she would not have otherwise treated me because I'm in that trial, I want to know that.
I guess I want to counter that, but do you know when your physician is treating you based on a pathway because of cost or an RVU?
Not always. I might ask, but I do want to know. It's if it's about me and my treatment, it is relevant for me to know that.
And I think a take home from this is, and we don't have time to dig into all the issues of CRTs, but I think a take home, Leonard, is that we do need to address this in this sort of research, and any guidance that's coming forward ought to be at least parse that type of research and at least describe why it applies or what it doesn't apply. Just because you had this dichotomized relationship, we know that healthcare takes place typically in settings with teams, with various drivers on practice, and if the guidance is purported to be helpful in having IRBs reach conclusions about this research, it's got to be sensitive to the realities of way clinic is practiced. I wanted to pick up on Rob's point about the reasonably foreseeable and Rebecca's IRB. So somewhere under the arch in St. Louis, they have their way of coming up with a reasonable foreseeable risk, which has some measure of what I understood of nature, frequency, and magnitude of risk that somehow put into they've added these components of risk to their determinations of what they're weighing and then also supposedly disclosing. The editors of the Regional Medical Journal that wrote the article put out a certain description of what they would see as reasonably foreseeable risks. And Rob's point, I think, is well taken. If we use as a proxy for what people see as reasonably foreseeable risks that are disclosed, we know when we look at consent forms for multi-center trials, they drastically differ. We know that the length of consent documents and risk information goes very long. In several group trials, all the risks of each medication are typically laid out. You can find 30, 40, 50-page consent documents that really do pick up every risk, and they're people, I don't know who they are or where they come from or their genetic makeup, who find other risks, and try to insert them in documents like a sport. And so, the problem with that is it doesn't help go to this materiality question. And so I think we do have a problem at hand. In another project we're working on, working with Amy Corneli, who's at FHI 360, looking at consent documents to see what multiple stakeholders think of the information in consent document, including risk information. And we're asking different stakeholders, patient participants, IRBs, research coordinators and nurses, officials, what do they think is really important in that document? We have them highlight, these are actual forms in use. Green for, I need that information, it's material. Red, I don't need that. And leave blank, I'm kind of neutral on that information. And we're in the process now of now analyzing a mass of data from 100 stakeholders, and we're going to try to build consensus about what we could get out of that. Now, that may not be the best way of addressing materiality, but I think we do need to address this problem head on, and it is at least conceivable for the kind of research that the editors of the New England Journal are talking about, that you would see a consent document like that. Other places might read it differently, but that's not a guidance that's going to be helpful.
I think that's terrific. But again, I think that's a broader issue in all human subjects research. It's not just particular to this. And I hope we can hear.
Thank you. Thank you. Thank you, everybody. It's so wonderful to get such wisdom going. And I think I'm anticipating some of the challenges Marjorie and I are going to have tomorrow when we have to put some things together. So an undercurrent that I hear is that some of what's in the current guidance is very similar to what's already in regulation. We have, as Ruth was saying, reasonably foreseeable risks. We have, as Nancy was saying, that we already, minimal risk is not going to get us to just waive informed consent for these kinds of research, because we have to think about respect and protections. And Len, I think, is making a wonderful argument with respect to why should this research be considered different. So the question I want to pose to the panel while you're all still here today is, what are the reasonably foreseeable risks of OHRP having guidance that singles out SOC as a very special type of research? One of the risks that I see is just an addition to IRB mission creep. Will IRBs now be responsible for trying to figure out in any particular study what is the risk of random assignment? We don't know. There is no empirical database for that. So, Len, I guess I'd like to start with you to take your suppositions further for, do we need this kind of guidance? And if we do, how do we present it from causing more problems?
Yeah, I don't think we need this kind of guidance. I think what we need to do is deal with issues of research as they come up. And different kinds of research, regardless of classification, presents different risks and benefits and alternatives and all the rest of it. I mean, we have to remember, although we're not supposed to mention the name of the study, which cannot be mentioned, is that this all derives from that. Right? So when one asks, why do they only look at risk? It's because that's what everybody was upset about. That this was about a study that was done in the context of doctor-patient relationships, which is why that's what I talked about. So I think that studies that are done in the context of the doctor-patient relationship are different than cluster randomized studies. And the best way to handle that in this guidance is to say it doesn't include that class of studies. But I think that, so when we look at it and we see what the concerns are about foreseeability and all the rest of it, you know, the New England Journal of Medicine editorial is problematic for a lot of reasons, but it's a caricature. It's like, take the worst possible outcome that you can get. And that's what they did. And you can do that with any study with any kind of foreseeability. Again, it doesn't have to do with this. So I think that, at least I'm not convinced today, that there were really very excellent panelists and very smart people have come up with a reason why this is special, why this has to be treated as a special case.
Before I follow, are you at the mic? Okay, let's take your comment, because we're going to, after your comment, we'll need to start to wrap up. And the question that, I have two questions for each of you who would like to speak. One is, do we need the guidance? And if we do, or if we're going to have to live with guidance. Yes, sorry. And if we do, do we need the guidance? Yes or no? And if we need the guidance, or if we're going to have to live with guidance, how should we define or normalize this term reasonably foreseeable risk? What can you, recommend in terms of standard or criteria for IRB's investigators to make that judgment? Go ahead.
So along those lines, I just want to highlight the fact that when you asked whether we could at least get consensus on what seems to be a relatively straightforward claim that if it's a purpose of the study, it's a reasonably foreseeable risk, there was no consensus. So if nothing else comes out of that meeting, I think that dissensus around that point is an important thing. And I think the reason has something to do with what Ruth was saying. I mean, and may have something to do with what makes comparative effectiveness research different, although I'd put comparative effectiveness research in the bundle of research that has a therapeutic intent and say, if a study has reasonable foreseeable risks and does not have complementary reasonably foreseeable benefits, it shouldn't be approved in the first place, unless it's approved as a study with no intention of benefit for the patient. And if it does have complementary reasonably foreseeable benefits, then at least if you're going to disclose some reasonably foreseeable risks, be sure to disclose the potential reasonably foreseeable benefits.
So if you look at the letter that was sent from OHARP to the University of Alabama in the study that has no name, that's exactly what they said. What you just said is exactly what they said. What they said is when you look at the consent form lists the benefits of randomization and does not list the risks of randomization. You just put one first. But that's all that the letter says, that you can't state the benefits of randomization unless you also state the risks of randomization.
It's not what the draft guidance says, as Jeremy pointed out.
No, but what I'm saying to you is that the draft guidance is not the only document that OHARP has ever written. What I'm saying is that this started with OHARP taking your position. That's how this started, and that it has blossomed into something else for reasons that some smart medical sociologist will figure out someday. But that's all OHARP said, is I agree with you entirely.
Surprisingly disagree with Leonard. Surprisingly, I think the reason we need the guidance is that there was a controversy. And the controversy has continued to simmer as it arose out of that nameless study. And without some guidance that from an authoritative body, either the controversy continues without resolution, or people read editorials and perspectives in a very prestigious journal and decide these guys must be right. I mean, after all, the editor of the New England Journal wrote 2 articles. Editors of other journals weighed in on that other study. 3 senior officials, including the director of the NIH, weighed in on this. And since all that controversy is not going to be resolved without some authoritative body saying something, things could sink to the least common denominator and use these absurd, outlandish examples as a standard. So that's why I'm respectfully disagreeing with you. When there's a controversy, there should be some kind of closure.
I don't hear anything that's been written or said today or written in the draft that's going to resolve this controversy.
Just jump ahead, because I think the question isn't, if the only question is yes or no, do we need this guidance? The answer is no, because we wouldn't be having this conversation for exactly this reason. And I think put in less clarity, if that's a word, is not helpful.
So as others, or if you want to, as you're giving comments, if you'd like to suggest what should be in the guidance, that would also be helpful. If we don't, if the 4 questions are not the right questions, or the answers aren't the right answers, make your suggestions.
Well, I'm agnostic. I thought the guidance was, I mean, we have this thing in law, hard cases make bad law. The study that shall not be named was a hard case, and it's generated all of this, and it's generated this document, which I found just seemed to state what I understood about things. Obviously, it's not. Maybe it's helpful in that it's clarifying that we're all over the place. It's kind of like the Terry Schiavo case. All the people in bioethics thought, oh, well, that situation is clarified, but it turned out it wasn't in the general public. So maybe it's helpful in educating us. I think you're never going to get satisfaction whenever you're asked to have a hard definition or recipe for something involving reasonable. Reasonable is, the reasonable person in law is normally interpreted by the jury of the peers of the defendant. Here we have this reasonably foreseeable risk. Well, who should be interpreting that? Scientific experts, physicians, IRBs, people whose lives would be affected by a change in the regulations? I think yes. But you are going to get diversity, you're going to get, different views, and maybe there has to be some decision about, okay, we're coming down this way, but the holy grail of a real reasonable risk definition, I don't think exists.
So, Rebecca, great points. And Len, I'm even more worried about you now because you called this a blossom, which doesn't seem like a blossom. This whole thing blossomed.
Yeah, the whole controversy.
Oh, yeah, and I was thinking about this beautiful blossom that we got. But I think I would, yeah, some kind of different definition. So the issue is, I think the issue that Rebecca raised about bad cases making bad law, or as Carol Levine said long ago, research ethics was born in scandal and reared in protectionism, and that's been problematic for a variety of reasons. And I think we really need to think forward about how to best get this right. I think we probably, for the reasons you outlined, do need some kind of guidance, and fantastic that we have a draft to look at. And it's great that it's called a draft, right? Because the draft is out there for comment and consideration. It clearly is clear to some attorneys who've worked in the area, unclear to many people who will be working on IRBs, investigators, and it's not likely to lead to decisions we'll be comfortable with. And so therefore it should be reworked. The ways that we could think about doing it, I think I mentioned earlier, we need clarity of terminology and definitions and consistent use. We could learn from demonstration projects that are going forward, and rather than to bring our assumptions forward about what any group wants or does, including IRBs, patients, participants, investigators, we should stand to gather those data to help inform that policy guidance. As a policy matter more broadly, if we are going to be relooking at the whole common rule, one of the things we've problematized as a result of this is this issue that's been around a while, that the reasonable foreseeability might be better altered to look at materiality so we can get back to the principles that were supposedly behind the regulations.
Susan?
I'm not sure I agree with the point that when there's a big controversy, something has to be done to bring it to closure. Before the controversy around the study that not be named, there was another very similar kind of study done called ARDSNet. We weren't told not to say anything about ARDSNet, but ARDSNet was also a low versus a high question, and the big issue there was what was the right standard of care used, and should there have been a middle dose, because and there was a huge controversy, and the New England Journal weighed in, and lots of other people weighed in, and I think there was a conference at NIH that talked about it. I don't know that any particular guidance or regulation or anything was changed by it, and in all that I've read about the study that has not been named, I haven't heard any complaints about it that they didn't look at the right treatments. That that kind of complaint wasn't made. We've had the whole issue with the placebo controls was a huge debate, and there were actions, and then those actions got changed, and now we're pretty much back to where we used to be. So sometimes I think maybe things just simmer and people think about it and kind of figure things out well enough and it goes away, and sometimes you make it worse by by doing something.
I don't think that we should avoid talking about controversial studies or even thinking about them. Just like patients want their doctors to worry about them, I think we ought to want investigators to worry about whether they're doing the right thing. And so these guidelines, no doubt, are not going to be definitive, nor should they be. Research, science, medicine, clinical work, we hope, is going to progress. New statistical techniques will develop, and they will present conundra. We should be looking forward to doing something logical, reasonable, but I don't think we should be looking for something absolutely definitive. Too many rules are no good, but we should make investigators worry.
Okay. I couldn't tell if someone else was coming to. Are you coming to the mic?
If I could just have a minute. Sure. So I've been a caretaker of a parent and a caretaker of a child, and this is all very new to me, and the word guidance sounds very simple, and it apparently is not. And I'm all for being protected as a patient, but the example that I've given in the past is I need a seatbelt, but I don't need 5 seatbelts and a crash helmet. And I'm very disheartened to hear everybody up here debate the people that need to debate. And I'm not hearing the word patient very much. I'm hearing you talk about the researchers and the investigators and the clinicians and the IRB need to really figure this out. You're leaving out a really important group of people, and that's the patient. And I think trying to write a guidance that covers all things for all patients in all situations, somebody with chronic skin condition is not the same person as a toddler with a terminal illness. For some people, the only outcome is death. So the risk that they're willing to accept is tremendously different. Nausea to me would be a fantastic risk, but for somebody else, it makes it unable for them to go to work. My child won't go to work, so a little nausea is not the end of the world. And I think for this room to think that you have the ability to come to an agreement on something for all people is just going to make it so much harder to get research done. You're tightening it to a point of constriction. So why can't the guidance be, we need to include the patient voice in the design of clinical trials every time, all the time, and let the patients at risk decide what's a risk and what they're willing to do, rather than try and agree on this philosophy of definitions. And I mean, people are dying, and we're trying to agree on something that's not agreeable. So I think maybe the guidance should be, let the patients into the conversation in the IRBs or into the laboratory where the clinical trial is being designed. Well, not just let them in, mandate that they be there. And then let them help you make that decision, rather than you try and fight it out here. And again, I come from a long line of doctors and nurses, but I have no extra initials after my name, so that's just my little spiel.
Thank you. And Don, you're going to have the last word.
So I think it's great. We should include patients. 3 of the 13 members of our IRB are parents of patients who have been in clinical trials, one of whom has a child who died. So there are ways and models to do that, and we turn to them often first when we're talking about how risks are presented to say, does this make sense to you? The other thing is that whether the new guidance is needed, I don't know, but we have had in our IRB application for, I think, 20 years, a long, long time, a question of if your research involves studying the current standard of care, describe how you believe this is a local, regional, or national standard of care, and then goes on to ask about number of patients involved and any adverse outcomes expected. So we can already do this. The guidance isn't necessary to allow us to do it, but I don't know how many institutions are asking that question, but it's been a relevant question, well, since the beginning. We haven't been asking it since the beginning, but it's been a relevant question for a long time.
I'd like to thank the presenters and the panelists for the discussion this afternoon, and we are out of time, and we're at a time where we're going to take a break, and I assume that we're still taking a 15-minute break, and so let's see, by my watch, that would be to be back by 5 till 4.